Thank you, and it's my pleasure to present today and thank Ethan Bash for organizing such an important program. So I want to spend a little bit of time talking about different types of biomarkers, talking about emerging biomarkers in prostate cancer, and then understanding how our growing knowledge of prostate cancer genetics and biology is hopefully going to help inform both screening and treatment in the future. So we are looking at prostate cancer, and as a medical oncologist, we talk about disease states. Today we're focused on the state of early diagnosis and when men first find out they have cancer. But across all of these disease states, there are decisions. And these decisions are something that the patient and the provider sit with and try to make the best ones to improve their overall survival. I think I want to start off by saying a biomarker really has to be, you have to focus on the clinical utility. So biomarkers should inform clinical decisions with respect to the need for prevention, screening, diagnostic procedures, local treatments, and systemic treatments. And if a biomarker is not helping you with that decision, one of these decisions, you have to question whether you should do it or not. Again, the question is not whether we can do something, but whether we should do something. So there are different types of biomarkers, and I'm not going to go into this in depth, but just to touch upon them so that we have the same vocabulary. So disease risk biomarkers, these reflect an individual's predisposition to disease. BRCA1 testing is a good example in breast cancer. Diagnostic biomarkers, and these diagnostic markers reflect the presence or absence of disease, and PSA, pertinent to our discussion today, is a diagnostic marker. Most screening biomarkers are diagnostic biomarkers. Prognostic biomarkers anticipate the natural history of a disease. So once you have a disease, what is the likely outcome? Predictive biomarkers are something we're all enthusiastic about and hope to get more of, and this anticipates a disease response to therapy. There are also a growing number of specialized markers, including monitoring biomarkers that reflect a response to an intervention, a surrogate biomarker, which is a monitoring biomarker that anticipates the impact of a therapy on a more remote outcome. So it is a monitoring outcome, but it follows a strict set of criteria established by Prentice for association with a more remote outcome. Companion diagnostics we're seeing more and more, which is an assay that identifies a subgroup of patients with tumors that respond to a specific therapy, such as the ALK fusions in lung cancer and crizotinib. And finally, pharmacodynamic biomarkers really help understand if a therapy, when given to a patient, hits its intended target. So we can obtain biomarkers from multiple sources, and there are a growing number of ways to access molecular features and biomarkers so as to inform our decisions. I like to break them down into genotypic and phenotypic. Genotypic, just strictly DNA. So you have germline DNA that you can get from normal tissues as well as circulating blood cells. You can look at that germline DNA for sequence, structural changes, as well as epigenetics. And then there's tumor DNA for the same changes that we can now obtain from multiple sources. So we're starting to see circulating tumor cells being collected from blood, disseminated cancer cells, free DNA that circulates. In urine, you can get tumor cells and look at both tumor cell DNA and free DNA, and then the tumor cells themselves. On the phenotypic side, I think about protein, RNA, microRNA. These are molecular features that can change with time. And we can get these, of course, from normal tissue, blood, urine, and tumor, and an increasing number of compartments within each of those. So in prostate cancer, where do we stand right now? And this is just a brief table summarizing. If you think about disease risks, I'm not talking about for localized disease. There are a number of germline polymorphisms that we know are associated with risk. There are some tests out there that combine some of these biomarkers, these polymorphisms. I'm not going to talk about that today. There are sessions later on in this meeting that focus on that. But suffice to say, I think it's still a field in evolution. Obviously, we're talking about diagnostic and screening, and we have PSA. And today I'll touch upon PCA3 that Dr. Scardino already mentioned, as well as the CONFIRM-MDX study. For prognosis, which is, I think, a critical element today, is that as we diagnose these men and put them at risk for overtreatment, more and more use of prognostic markers to help inform whether active surveillance is appropriate or whether definitive local therapy is appropriate is critical. And I'll touch upon the Oncotype DX, Prolaris, Decipher tests today. We do have some of these in metastatic disease as well, although that's not the focus of today. Unfortunately, to date, we do not have a predictive biomarker in prostate cancer, nor do we have a companion diagnostic or a pharmacodynamic. We do have some monitoring biomarkers, such as PSA change in both local and metastatic disease and CTC change in metastatic disease. While there have been many attempts to see if some biomarkers meet the level of meet Prentice criteria for surrogacy, few have met all the criteria. The one that has come closest is CTC change in the setting of abiraterone, but only in advanced disease. So today, I'm going to focus on clinical utility and walk through how to improve diagnosis with emerging biomarkers, how to identify men with clinically indolent disease and avoid unnecessary treatment, how to identify and treat men with high-risk, life-threatening prostate cancer, and touch upon where biomarker development is going. So how do we improve diagnosis? So this is a timeline of PSA, and obviously the first three speakers really focused on the current state of the art of PSA. I think I put this up there to stress that it's been 40 years since PSA has been diagnosed. It took approximately 13 years for it to get approved by FDA for monitoring. Remember, PSA was first approved as a monitoring. It was then about 7 years after that it was approved as a screening test. And you can see there's further evolution, and it took 15 to 20 years after FDA approval before we finally had the randomized controlled trial to really assess the clinical utility of this PSA. So with prostate cancer, I think the reason I show this is the bottom line is, given the natural history of localized prostate cancer, any biomarker to improve upon PSA faces a significant challenge with respect to prospective trials, strictly due to the natural history. These are some modifications of PSA. Dr. Scardino went into detail about one specific one that he's involved in. He also mentioned the PHI. These are showing promise, but again, they're in different levels of validation. As well as PSA variations, we have a whole host of novel biomarkers that have been identified in the serum that are associated with prostate cancer diagnosis. I know this table is hard to read, and I don't put it up so that you recognize each one of them. Hopefully I have your favorite one on there. But suffice it to say, there's an incredible list, a growing number of potential serum or tissue-based biomarkers. Now, why do we not have more tests, and why aren't we talking about more than PSA today? And there are challenges to that each of these face. So there is a plethora of candidate biomarkers with preliminary data. The assays are often performed in research laboratories without sufficient analytic validation. So analytic validation means when you measure an analyte, you get the same value when you measure the same sample again and again. Oftentimes, even with analytically valid biomarkers, they are initially tested in kind of ad hoc cohorts. And there are a large number of biases that can be introduced into these cohorts that are oftentimes not controlled for. There's oftentimes modest independent validation. There are ways to look within data sets to do leave one out cross-validation or fold validation, resampling approaches, but what is really required for validation is an independent data set. And there's oftentimes faulty statistical design and/or analysis included. And finally, in order to go from a laboratory-based test to a clinical assay that you can order, it requires incredible resources and requires robust analysis of independent validation to go from the laboratory to a CLIA CAP-certified laboratory. So let's talk about two in the kind of diagnostic realm that have met that criteria in my mind. The PCA3 is now commercially available. It was first described back in 1999, so its timeline started just over 14 years ago. It's a non-coding mRNA species that is found in the urine. Its sensitivity is 67 and has negative predictive value of 90%, so it's pretty good performance status, and there are multiple studies that have looked at this in independent data sets. It has been found to be superior to PSA in predicting prostate cancer in men with elevated PSA and a previous negative biopsy. And that, as we'll stress again, is what it's indicated for. It also has some potential future opportunities in that it's associated with aggressive disease as far as extracapsular extension and tumor volume. However, there has been a study looking at can you use PCA3 in the setting of an active surveillance cohort to decide who is likely to have poor pathology or upgrading, and that has not been supported by the data. So what is the clinical utility? What are the questions that are currently PCA3 may be positioned for? So the first, which is the FDA-approved indication, is the risk of cancer for an individual with a negative diagnostic biopsy. So these are men who've had some reason for their providers to do a diagnostic biopsy. They had a set of biopsies. Their biopsies were negative. In that setting, a PCA3 test result can really help decide whether further biopsies are required to make a diagnosis. So just to mention one study looking at the REDUCE participants, the assay was measurable in 94% of the patients, so it's often present. And when they put PCA3 and PSA together, they had a marked increase in the diagnostic accuracy in predicting who was going to have a positive biopsy on their next biopsy. There's also a decision regarding the initial biopsy. So this is where it would be helpful before you have a negative diagnosis biopsy. You have a PSA value. You consider the man at risk for prostate cancer, and you're considering a biopsy. There has been a study that looked at this. It was a European study, prospective, 516 men who are at risk and planned on having a biopsy. And they found that PCA3 did have a higher AUC using receiver-operated characteristic curves than PSA total, PSA density, and percent free PSA. So there's some promise there, but that's not FDA indicated yet, and more data is required. And then finally, I've already mentioned the risk of upgrading during active surveillance. So this is the FDA approval from February of 2012, and I do want to mention two black box. The first is that when you see pathology with the atypical small acinar proliferation, which we know are associated with the presence of prostate cancer, the assay is not considered valid. So anytime you use a biomarker and use an assay, you need to know when it is valid. So that's one caveat. The other caveat is that the performance of the PCA3 has not been established in men who are not considering another biopsy. So it's a very specific indication. Another test that's out there that is marketed as the CONFIRM-MDX study looks at GST-Pi methylation. Now, we've known for years that GST-Pi promoter methylation is one of the earliest molecular events in prostate cancer. Bill Nelson and his colleagues at Hopkins have pioneered this. What has been found, and it's been looked at as a potential diagnostic because it is so commonly found. What is known is that if you look at tissue levels, you see GST-Pi methylation about 94% of patients. They've also looked at other analytes. So they've looked in the serum, they've looked in the ejaculate, and you looked in the urine. Unfortunately, you see a significant drop-off in the prevalence of GST-Pi methylation unless you're in tissue. And so the assay that has moved forward is a tissue-based assay. And it's important to note is what it's working on. The biology that's behind this is the field effect that we talk about in prostate cancer, where the presence of prostate cancer affects the benign tissue around it. And it's very clear from multiple studies that if you look at GST-Pi methylation, not only do you see it in the neoplastic epithelial cells and the cancer epithelial cells, but you see it in the benign epithelium that surrounds. This is the clinical utility. So what CONFIRM-MDX suggests is that when you have a PSA screening and wish for a biopsy, consider a man at risk, they get a negative biopsy. Residual tissue, so again this is tissue-based assay, can be performed at CONFIRM-MDX. If they do not see methylation, you go back to PSA screening, and if you do, it recommends a repeat biopsy. So what are some early conclusions for diagnostic biomarkers? So first, PSA has challenges, but it remains the best serum-based marker for diagnosis of prostate cancer. So the three speakers before me, again, we're still debating the proper use, I think, but right now, we don't have anything better. I think what Peter showed and what we're seeing is that there are some emerging biomarkers that are serum-based that could contribute and improve upon both the sensitivity and specificity, but none is ready for prime time at this time. Part of the problem with that is the transition from a laboratory-based assay to a clinical test requires the rigor samples and a significant financial support. And additional markers showing promise often fail to come to market because of inadequate analytic or clinical validation. And finally, the urine PCA3 and tissue GST-Pi methylation assays may help reduce additional biopsies. I guess my major question as we look about diagnosis is that I think the discussion today is about overdiagnosis of indolent disease. I don't think it might be heresy, but I don't think we need a better diagnostic test as far as finding the disease. We need a better diagnostic test that can find clinically important disease. So that moves on to prognosis. So what do we have that can help with prognosis? Now, what we do have and what we've had for many years are tables, nomograms, or scores that combine PSA, Gleason, and clinical elements to give an assessment of outcome, be it biochemical recurrence, or in the case of the CAPRA score developed by Peter Carroll and Matt Kuperberg at UCSF, prostate cancer-specific mortality. So we know we can do pretty well, just understanding that based on the biopsy. The challenge is that if we're doing so well in that, we should be able to see more men opting for active surveillance, and we should be able to avoid the challenge of overtreatment. Now, Dr. Scardino showed a couple plots and I think it's good news that we're seeing more adoption of active surveillance. This is from Judd Mao looking at the prostate cancer program at Duke, where approximately 10% of patients opt for active surveillance. Nationwide right now, it's about 14%. So we need to go much further in understanding how to support men in their decision to stay on active surveillance. So there are two tests that I feel have gone through analytic validation that are in this field that are worth mention. So there's Myriad's Prolaris test. This is a tissue-based test. It requires approximately 5 millimeters of prostate cancer tissue on the biopsy, macrodissected, and looking at the expression of 31 cell cycle genes and 15 housekeeping genes. This is an RT-PCR-based assay, has a linear range, and has good coefficient of variance. And the outcome of interest is biochemical recurrence. This has been tested in 2 cohorts, a relatively large, an initial and a validation, and we see the score range. In addition, they have looked to see if the Prolaris score works together with to add information to the CAPRA score. So many biomarkers look in isolation without taking into account Gleason and PSA. They've looked at both. So if you look at the combined, if you look at the score, this is not surprising in that their score does correlate with Gleason. So in this, gray is Gleason score less than 7, light orange is 7, dark orange is greater than 7. You see that as score goes up, patients with a higher Gleason have a higher score. In effect, if you send your patient samples biopsy off for a score, you can have this online where you can put in the clinical features, put in your Prolaris score, and you'll get a risk. What you'll notice when you get your risk back is that for the majority of patients, they will have a pretty moderate risk. However, they know that with a combined score of 2 or greater, there's a greater than 50% risk of biochemical recurrence. And this may help you make decisions with respect to your patient. The Oncotype DX Genomic Prostate Score, GPS, is different. This was just presented at AUA last month. They followed a very similar development pattern as they did with their breast cancer specimens, going from candidate genes down to a signature. The outcome that they focused on is that what are the risks of a man having adverse pathology when they have their prostate taken out? So this is right in the realm of active surveillance, and this is to help men who have had diagnostic biopsies, have cancer, and they're asking what's the chance of there being worse cancer if I have therapy. Eric Klein at Cleveland Clinic helped them develop this, and then the urologists at UCSF, Peter Carroll and Matt Kuperberg, provided the validation study. This is the list of the genes, and like the breast cancer study, they have a set of different families of genes reflecting different functions in the cell. Androgen signaling, very appropriate, proliferation, cellular organization, and then their reference. This is RT-PCR based exam, and coefficients are used based on the expression to bring these together. So if you look at whether this adds independent value to Gleason, age, PSA, multivariate analysis is required, and this is the results that Matt Cooperberg presented last month. And you see that the GPS score in multivariate analysis does have independent strength. Gleason remains also very strong, and the other all remain significant, but providing independent. Thus, you can combine them, and it will give you more information. If you look at the Capra score, again, a composite of these factors, the GPS score remains strong and remains having independent value. I showed this data because, as is likely a trend, whenever you look at a biomarker, is it better than any single gene? And this shows just a list of the different genes used in the signature and how their hazard ratio, odds ratio are with respect to bad pathology. And you can see the individual genes do not outperform the combination. And finally, with respect to clinical decision, how does this score affect a patient's assumption of risk? So if you look at the cohort, the validation cohort, and you break them down into Capra score, and you look at their risk of favorable pathology, you can see Capra score 0 has a very good favorable risk of pathology, whereas a Capra score 4 has a relatively low. If you then perform the GPS test, this is the spread within each of these categories. And importantly, it affects about half of the patients will have a greater than 5% change in their risk of favorable pathology. And even more importantly, the number of patients with a very good risk, so 80% risk, at least an 80% risk of having a favorable pathology, goes from 5% to 24%. So this test is very much aimed to help support the decision of active surveillance. So what are some conclusions? There are no prospectively validated single molecular assays that anticipates behavior. Many published studies associating immunohistochemistry markers with prognosis. Few markers are found to be associated with prognosis are also found to be independent of Gleason sum. Most of them just are surrogates for Gleason sum. And biochemical recurrence is not strongly associated with lethal prostate cancer and should be used with caution as an important outcome for biomarkers. And finally, I think genomics health test helps with the detection between decision between active surveillance and definitive local therapy, and therefore has clinical utility. Now, how do we identify and treat men with high-risk, life-threatening prostate cancer? So we know, again, looking at this, in this case, some of the data out of Hopkins, that men with high-risk disease, we're talking about a different disease than those men with very low-risk disease. And if you're age 55 to 59 and you have Gleason score 8 to 10 and you do not seek treatment, you're very likely to die of prostate cancer. I think this is also important because, as the data shows from the first 3 presentations, if we stop screening, we will see more high-risk localized prostate cancer. That's just going to happen without screening. Now, there's level 1 evidence. The good news is that for men with high-risk localized disease, that multimodality therapy does improve survival. So Dr. Scardino showed that, unfortunately, many men are treated kind of nihilistically with androgens alone, but there's multiple studies showing that combining surgery with androgens or radiation with hormones or adjuvant radiation after surgery can improve outcome. The Genome DX is a company that has the assay called Decipher. This is an emerging assay. It's available through kind of research agreements now, but they're moving forward and applying and talking to the FDA. This is also an expression-based test. It uses an Affymetrix genome-wide expression platform. It does not use RT-PCR. It's a 22-gene signature that's associated with the development of metastases. They've worked very hard with the Mayo Clinic to obtain a high-quality data set, and they have over 1,000 samples of high-risk prostate cancer where they know biochemical recurrence, they know those who had developed metastases, and they know those who had prostate cancer-specific mortality. So they have very good hard endpoints, which is critical to the development of biomarkers. They have outstanding long-term follow-up, and they've divided their test into training, test, and a blinded validation assay. So they've also compared across all the expression-based assays, and suffice it to say, they've done a rigorous job. Ethan mentioned that we were the first to publish a multi-gene marker. This is ours here. I guess being first has its problems. We weren't one of the best, but they've looked at each. Now, it's always important when you look at these comparators, they've included Oncotype and Prolaris here. But keep in mind, they use a different platform. So this is all using their Affymetrix data, taking the same genes and the same coefficients, but it's not the same assay. So it's hard to make direct comparisons. However, what is critical about their work and what is characteristic of strong work in developing biomarkers for the future is that you have the training and the validation and allow some comparison across. This is some data that it looks like. So if you look at their score, the Decipher score, along the x-axis, these are colored for patients who subsequently developed early metastases, late metastases, white is no metastatic follow-up after a median of 8.1, so this is in the validation. You can see a higher Decipher score is strongly associated with the development of metastases. And in prostate cancer, while biochemical recurrence is only modestly associated with mortality, the development of metastases has a strong association with mortality. So what are some conclusions for this section? So we have an increasing ability to tailor treatment recommendations based on the aggressiveness of localized prostate cancer. Multimodality therapy for high-risk prostate cancer does save lives. Novel molecular assays may help identify men most in need of adjuvant therapy. I think what we're going to need to see, this is all promising and the Decipher test looks good and there'll be others that come, but I think what we really need to see when you get to clinical utility is if you do find those men at the highest risk of recurrence with a test like Decipher, do those men actually benefit from more intervention and more aggressive therapy? So finally, where are we heading? So along with these decisions, we know that as prostate cancer develops, there is a molecular evolution that occurs on. And every individual's journey, as far as their tumor's journey of molecular acquisition of sequential genetic events, is individual to their own. The good news is that we're starting to build the catalog of prostate cancer. So through the efforts of investigators such as Roel Chanayan, Levi Garraway, and larger efforts that involve multiple people like the Tumor Genome Atlas program, we are starting to build the catalog. We are very close to knowing the catalog of prostate cancer as far as what are the copy number variations that are commonly seen, what are the genes affected, and what are the mutations that are commonly seen. We also have next generation sequencing that is now becoming readily available. Many of you probably know about Foundation One or other sources where you can send a tumor and get 20, 200, a number of genes sequencing uses technology. As technology develops, there's an increasing coverage at decreasing cost, and we'll see more and more of this coming down. For prostate cancer, what are we going to see? So we know the catalog, and now we're getting sequencing. And I think the challenge, again, will be, if you do this type, what can you do with the information? So we'll be able to identify AR gene mutations, ERG fusions, PTEN loss, and the remainder of these are the most common events seen. And the goal will be to turn these into predictive biomarkers or companion biomarkers where we use this information to specifically guide therapy. So whereas the Decipher and the Capra score can tell us that a man has high risk and is in trouble, by knowing the genetics and understanding the driving genetics, the hope is that we use the genetics and the specific genetic events to choose specific therapies to change their outcome. We also have other places that are looking exciting and where we hope to have information to guide therapy and make decisions. Circulating tumor cells are certainly already available for men with advanced disease as far as enumeration. But the excitement about circulating tumor cells has less to do with their number and more to do with whether they can serve as liquid biopsies. So can we use genetic events, protein expression, RNA expression in those circulating tumor cells to assess what the tumor, the metastatic or local tumor, is doing, and make decisions as far as therapy based on those events. And that's going to be exciting. This is a slide from Andy Armstrong, who's showing that while we're focused on identifying circulating tumor cells that look epithelial in prostate cancer, we have to know that metastasis involves epithelial to mesenchymal transformation. And he has shown nicely that not only are epithelial tumor cells circulating, but some tumor cells are circulating look mesenchymal, and we'll have to see the implications of that. Finally, imaging. I haven't mentioned imaging. I've been focused on the molecular biomarkers, but imaging is getting more and more molecular. Not only are we seeing whether disease is there, but we're getting an assessment of its metabolism, and through that, I think this shows great promise in better understanding the difference between an indolent tumor and perhaps a tumor that is more aggressive. This is a slide from John Korhanowitz showing his recent work in hyperpolarized C13 pyruvate, where he can use difference in the metabolism, whereas if you look at a standard T2-weighted MRI, you see one lesion, but you don't see any activity on the opposite side. If you look at metabolism through this, you see a strong activity on the opposite side, and this is biopsy confirmed. So I think what I am so more excited about with imaging rather than finding more disease is that with molecular imaging, we can focus on finding the aggressive disease rather than just more disease. So just in conclusion, there are a number of emerging molecular-based biomarkers that contribute to prostate cancer diagnosis and prognosis. While biomarkers have analytic and clinical validity, clinical utility is a key for biomarker adoption, and our assessment of biomarkers should always involve the question, how am I going to use this marker and how will it benefit the patient? As we build the genetic catalog of prostate cancer, biomarkers will be used to identify subsets of patients for specific therapies. While we're not doing that yet, obviously lung and breast cancer are doing it, as well as colon cancer. We'll see that coming for prostate cancer. And CTCs and other blood-based markers offer potential for liquid biopsies. We're still looking for proof of concept, but it is exciting. And finally, molecular imaging is likely to contribute to the prostate cancer management. I just want to acknowledge people who shared slides with me, and thank you for your attention.